Welcome everyone to today's webinar. I'm Molly Gamble, Editor-in-Chief of Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter Your Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Mukesh Gangwal is President and CEO of Prism Healthcare Partners, a national healthcare consulting firm. He helped co-found Prism in 2013 and has over 30 years of experience improving the financial and operational performance of community hospitals, health systems, and academic medical centers across the United States. Mukesh is an expert in large-scale performance improvement projects, revenue cycle management, physician services, and turnarounds. As a former leader at global consultancies such as Arthur Andersen and Bearing Point, Mukesh has advised boards and management on cost and revenue improvements, often resulting in up to $100 million or more in annual recurring benefits. George Wetzel is Managing Partner and co-founder of Prism Healthcare Partners. He has more than 41 years of consulting experience serving the healthcare industry. George is a nationally recognized expert in cost and quality management and has assisted hundreds of healthcare providers with their efforts to improve quality and reduce costs. Through his deep experience at Prism and with prestigious healthcare consulting leaders, including Wellspring Partners, KPMG, and Ernst & Young, George is adept at helping boards, medical staff, and senior management successfully implement the changes necessary to reposition their organizations for success. Mukesh and George, we are so grateful to have you with us today to share your expertise and observations on a topic that is certainly of great concern and of great interest to hospital and health system decision makers. The repeal and replacement of the ACA, particularly in light of the events that unfolded Friday in Washington, D.C., presents many questions as to how organizations should move forward. The leaders face some big decisions on how or whether they should adjust their strategies for value-based care, physician networks, and capital expenditures. We certainly have a lot of ground to cover in the next few minutes, so let's get started here. George, can you begin by sharing your insights on what happens next after the developments of last Friday when the working ACA replacement plan was withdrawn?
Okay, thank you, Molly. Well, the last week to 10 days leading up to last Friday was certainly one of the more interesting periods in healthcare. I think our listeners need to think of this in the context of not so much a complete failure as a delay. That there's going to be some time to regroup, but the Republican-controlled Congress has all run for the last 8 or 9 years on the repeal and replacement of the Affordable Care Act, so I don't think they're going to give up, and it's going to go away. I think we're going to see renewed efforts to repeal, or at the very least, drastically alter the ACA. So, and the fact is, what they were trying to do was a bit of a parliamentary gamble anyway. It wasn't likely to succeed. They tied it to the Senate rules on filibusters and the budget reconciliation process, and the bill that got pulled last week was probably never going to make it through the Senate. But it does give us some insights as to what the game plan is and what kind of changes they're likely to go after, whether it's changes to the ACA or replacement of ACA. There was a huge push to scale back Medicaid, convert Medicaid to block grants, and significantly reduce the federal government's commitment to funding Medicaid. There were some steps to eliminate the mandate that everybody has health insurance, and we already have seen that President Trump has directed the IRS not to aggressively enforce that. So we're likely to see a decline in the number of people with insurance because the penalty is not going to be enforced. There are things that can be done from a regulatory standpoint up to a point without requiring any act of Congress. Some of the subsidies could be shifted or reduced. I think we're going to see subtle changes to ACA because there's going to be a lack of support at the administrative level and the congressional level. And I think we need to keep in mind that the ACA included projection of $290 billion of reductions in Medicare reimbursement, and that's still out there in place. So I think part of what we need to keep in mind is whether we like it or not, what they were attempting to do was to build a tax cut and tax reform program around repealing the ACA, with more tax cuts and more tax reform to come. The Republican Party is definitely moving toward cutting taxes and reforming taxes, but they don't want to blow up the federal budget. And we all know that roughly 80 to 85% of all federal expenditures are in Medicare, Medicaid, Social Security, and defense. They're proposing to increase defense. They've already indicated they're prepared to scale back on Medicaid. Probably won't touch Social Security, and Medicare is the last place to go. So I think what we're going to see over the next the balance of this year and into next year are efforts to rein in healthcare expenditures at the federal level, and that's going to roll up to hospitals and health systems and physicians in terms of their reimbursement.
Great, thank you, George. So it sounds like whatever happened on Friday, irrespective of that, the pressures on the industry are going to continue to intensify. Mukesh, is there anything you wanted to add on to expand on what George just said?
Yeah, in the absence of repealing and replacing the ACA, what we have to learn from is the tone being set by the new administration. President Trump passed an order which directs departments to, quote, waive, defer, grant exemptions from or delay the implementation of provisions that impose burdens on states, companies, and individuals. Now that says a lot. Supplementing that is Secretary Price's comment on mandatory payment, for example, on joint replacement, where he concluded that such CMS innovations are experimenting with America's health. So, as George said earlier, within the broader context of ACA, administration has authority to mandate changes, not legislative changes, but administrative changes, which has far-reaching impact on the cost, delivery of healthcare, which will impact the providers. Individual mandates will not be enforced. For example, the reimbursement for cardiac care has, the changes in that has already stalled. 50% of the Medicare payment, which was supposed to go on an alternative model by 18, we can see changes coming to that. So, it would be an ostrich-like behavior if we think that the fact that repeal and replacement of ACA did not happen would mean that the status quo would remain. I think the political and the administrative undertones of ACA are so overwhelming, we shall see continued incremental changes, maybe not transformational changes, but definitely deep incremental changes, and providers need to be prepared for that. And over the next few questions, we will try to address those important and challenging issues facing the healthcare industry. Molly?
Great. Thank you both. I think you set the stage wonderfully there. And as you said, Mukesh, we have a lot to unpack here. So I think the first question we're going to dive into is the big picture with strategy. And George, I would love to hear your thoughts on this first, but how should providers approach strategy in this changing healthcare environment?
Molly, this is a broad question, and strategic decisions as for hospitals and health systems, given there's little certainty as to what direction things are going to take, makes it all the more challenging. My view would be that there's going to need to be a renewed emphasis on rationalizing services, programs, and locations of what the organizations currently have. So for standalone community hospitals, they need to take a step back and really assess their programs and services and whether, as they look to the future, they can maintain everything that they have. You know, are there things that they need to consider divesting or closing so that what remains can be financially successful? I think the community hospital idea that they can offer a whole array of services and have the more profitable services carry the services that aren't profitable or that actually lose money is going to be an increasingly difficult challenge for standalone hospitals to deal with. I think for multi-hospital systems, they're going to need to re-challenge their efforts to achieve economies of scale as a result of mergers, where they can reduce duplication by creating shared services functions that reduce overhead costs so that the cost of the 3 or 4 or 10 or 50 hospitals that they put into the system is lower because they're sharing some of the back office functions. They're going to have to take advantage of those opportunities. They may also have to challenge where they have multiple hospitals serving the same broad market area, whether they need to rationalize the services, rationalize locations, not have competing hospitals within the same system offering competing services. So, and all of those are very difficult strategies to implement because of the resistance to change and some of the protectionism that's just inherent in the systems. I think this is sort of a version of strategy, but I think a lot of providers are going to have to take a look at how they get value from the information technology investments they've made over the last 5 to 10 years. There's been huge amounts of money put into electronic medical records, electronic health records, automated scheduling systems, and it's now time to figure out how to get productivity gains out of those IT investments. And then finally, I think there's going to be renewed efforts to engage physicians, both employed and private practice physicians, in support of efforts to improve quality and reduce variation in practice, reduce length of stay, support the shift from inpatient to outpatient. Many of these things require clinical decision makers, and it's really the physicians that make those decisions. So engaging them as part of the team is going to be essential.
Great, thank you, George. Mukesh, I want to move on to hear some of your thoughts about the operational issues that hospitals and health systems are facing. But first, I want to make sure that if there's anything you want to add on to what George just said. He gave a long laundry list there of some big issues that hospitals and health systems are going to really need to dig into. If there's anything you wanted to add there, otherwise you can dive into hearing about some of the challenges that hospitals and health systems might face from an operational perspective.
Yeah, thank you, Molly. I'd like to make one comment on the strategic framework in the new healthcare environment, and then connect the dots from an operational perspective. So, the healthcare industry has to align itself with the commercial model of other industries. Now, what does that mean? It means management agility to quickly respond to market changes, whether it be regulatory or competitive, investment based on return on capital, not investments based on pure market share or growth, and a cost quality model which is sustainable. So if the healthcare industry backs off from pure politics and regulations and go and start getting more into running an organization with strong management processes and serving their shareholders, that probably is an orientation which we should consider and embrace quickly. Now, if I take that to its next level of understanding and thinking, we have to give it an operational thrust. Now, Toby Cosgrove recently said, he's the CEO of Cleveland Clinic, that 52% of hospitals in 2016 did not make any money in the U.S. Just think of the statement. Half of the healthcare industry, with $3 trillion spent in that, and 50% of the hospitals have 0 or less operating margin. So this sounds like the feast and famine sort of a situation where there's a lot of money being flowed into a certain sector, but there are segments within that sector which are inefficient or where the delivery of services is cost prohibitive. So translating that into action would require hospitals and health systems to look at their overall margin and their methodology towards margin maintenance. Now, margin maintenance requires a clear understanding of your cost structure and your revenue stream. Cost structure lines itself very cleanly and clearly to clinical resource consumption costs. So it's the labor cost, it is the non-labor cost, it's the clinical delivery of services, for example, the length of stay. It includes the investments made in your physician practice areas. It includes maximum net revenue realization, and honing in each one of these areas with relentless focus within the framework of the law. Now, tied to this also is an environment where reimbursement is going down. The indigent population or the underinsured population is growing up formidably. Whether it's under ACA or under ASCA, we will see either very high deductible plans through exchanges or a lesser population of insured people. Again, managing the self-pay portion of revenue cycle would be critical as we move forward. I'll just talk very quickly on 2 elements of costs which are very important to understand, evaluate, and leverage. One is labor cost. Labor represents probably 58 to 60% of the overall cost structure of any health system. And within the labor cost, there is obviously the FTE cost and the labor mix cost. And it's imperative, it's almost a travesty if a health system does not look at its overall cost of supplying labor for clinical care. Moving on to the non-labor costs, which include supplies, purchase services, etc., negotiating, whether under a GPO environment or outside, working with physicians on their preference items, but using scale and size and negotiating abilities and managing cost in the non-labor side is very, very critical. I could go down a laundry list of other areas where cost containment, cost management is important, but I think overall we have to get into this cost reduction model that the future lies in an operating environment where cost and relentless attention to reducing costs, not by diluting quality, but by actually enhancing quality, but being prudent on cost and investment is probably the mantra for the future. Molly?
Thanks, Mukesh. So I think you really segued to this next question quite well. When you talk about margin maintenance, you have to look at the cost structure and the revenue stream more closely. A huge component of the cost structure, as you said, is the labor cost as it relates to physician networks. So under the ACA, many hospitals and health systems really intensified their physician employment strategies and built up broad networks of employed physicians, which can create some challenges and complications for them in terms of cost containment. George, can you talk a little bit about this and what you're seeing or what you would advise hospitals and health systems do as it relates to their physician networks?
Sure, Molly. I'm going to just overlap a little bit with what Mukesh said, because what they need to do for the physician networks is almost identical to what they need to do for the rest of the hospital inpatient outpatient business. I think a lot of this comes back to redesigning, or in some cases designing, work processes that use less resources and leveraging the automation investments that they've already made. And I don't want to sound too draconian, but to reinforce what Mukesh said, wages, salaries, and fringe benefits represent roughly 60% of most healthcare providers' costs. And if you're going to reduce costs, you're going to have to reduce the size of your workforce. There isn't any way to really save a whole lot of money if you're not going to tackle that. And so what everybody needs to be challenging themselves to do is, how do you develop patient care delivery models and patient care delivery systems that use less resources, less staff than what you currently employ. On the physician network side, as you said, the vast majority of hospitals and health systems now employ physicians, and not just as pathologists and radiologists and hospitalists, but also in primary care, in some cases specialty areas, cardiac care, surgeons in some instances. Some of the organizations we work with have small networks that may only be 15 to 25 physicians, but a number of our clients have huge networks that employ several hundred, 300, 400, 500 physicians in multiple locations. They're running huge physician enterprises at this point. Most of them are struggling to figure out how to make the economics work. The financial statements often show the physician enterprise losing money, and that the losses are then subsidized by the balance of the hospital inpatient outpatient business. Because of the basic structure of the businesses, where in many cases the ancillary services and diagnostic testing services that the physician enterprises used to offer in competition with the hospital have been taken out and put into the hospitals, it's hard to make the economics work, but you do need to minimize the subsidy. It's going to be increasingly difficult for hospitals and health systems to make huge bottom line profit margins, so the amount of money that they're going to have available to subsidize the physician enterprise is going to go down. A lot of the same issues. Physician networks have revenue cycle systems. They need to do a better job with point of service cash collections. We're finding in many of the organizations we work with, one of the key things they need to do is to make access to the physician network easier. It needs to be easier to get an appointment and get in to see a physician or to see your physician. I find it interesting. I can go online and make an appointment at the Walgreens that's about a mile from my house, and it's instantaneous. Very few physician networks where I can do that. And even if I make a phone call, in many cases I can't get an appointment right away. So being able to not have that business go somewhere else is essential. There are also issues with staffing levels and productivity, and not so much the staffing and productivity of the physicians as the support staff, the nurses and administrative staff that support the physician enterprise. So it is a challenge, but if you're employing 100, 200, 300 physicians, you've got a multi-million-dollar, tens of millions of dollar business, and you can't afford to have that business have a negative 1 or 2 or 3, 4% operating margin.
Absolutely. Thank you, George. Mukesh, is there anything you wanted to add on to that? I think that was some really interesting comments George made, especially about the access to the physician network, too.
Yeah. Physicians and clinics are the front line of healthcare. They also provide essentially the value stream to providers, to hospitals. So historically, the physician practices and hospitals have had somewhat fragmented relationships in terms of patient flow, in terms of a joint incentive to do the right thing from a cost-quality perspective. Obviously, the physician networks, the faculty practice plans are driven much more by individual behavior as compared to hospitals, which I think for the most part operate in a traditional corporate model. So what does all this mean? I do think that in the future, physician networks will have to align themselves much closer with the provider, especially in the outpatient setting, where the clinics, the outpatient care delivery model will be very closely entwined between the physician's office and Part B for the hospitals. So that closer coordination of clinical care, patient access, we have noticed again and again in the marketplaces that there's a patient who wants access to a specialist or to a primary care physician, and there is no availability for the next several weeks, if not several months. So patient access and using algorithms to better avail of patient and physician synchronization in terms of availability of time, etc., is hugely critical. The aspect of accountability, especially for quality, is going to go up. Tighter emphasis on case management and removing clinical redundancies, practice of defensive medicine in the absence of very clear tort reform will become challenging. So the whole physician area, physician operations, physician strategy, going back to what George was saying earlier, will face similar challenges as the hospitals will. And working together in joint solutions, joint management processes is going to be really important. Molly?
Thanks, Mukesh. It sounds like the pressing areas for physician networks and hospitals aren't too different, really. You kind of covered a lot of these already, but labor costs, workforce efficiency, rationalizing services and locations, really focusing on those self-pay patients in the broader revenue cycle, getting value from IT investments. You've mentioned a lot of big action items. Are there any other pressing areas hospitals and health systems should really dig into and examine to further strengthen their performance?
Yeah,
Mukesh,
so I think, yeah, thank you, Molly. I think we touched on a lot of the areas which require addressing to strengthen performance, but there are a couple of areas which I'd like to focus on, which lends itself looking at the world of hospitals and physician practices and ancillaries in a different light. One of them is system and scale coordination. Now, what it means is we are seeing more and more sizable mergers and acquisitions and transactions in the healthcare world. There was a fashionable model of management which was based around core competencies and centers of excellence. Nowadays, the pendulum has swung on the other side. There is added emphasis on using the systemness of an organization, which is the size and scale of a large healthcare system, to centralize, consolidate, standardize processes, and use the scale to get the most competitive advantage in local markets. So that's going to become more and more important, where operating units are going to look at corporate to providing value-added shared services at competitive costs. Corporate is going to look at operating units to remove redundancies in back office processes and systems. So that's an important area which I think hospitals and health systems need to focus on. The other thing which I think is important, which George alluded to in our first question regarding strategy, would be just to look at overall capacity and the size and strength of clinical service lines. Too many smaller health systems, smaller hospitals are in too many services, whether it's cancer care, whether it's cardiac, whether it's orthopedics. There seems to be a redundancy, an overcapacity, no matter which way you look. So I think institutions have to get smarter to focus on which space do they want to play in, where do they want to excel in, as compared to being a mediocre provider of services in a vast array of clinical areas, which doesn't lend itself to profitable growth. So profitable growth, profitable focus on certain key service lines, coordination with other competitive systems in balancing out market needs, all within the framework of compliance, et cetera, I think will become very, very important. So I think these are some of the thoughts and thinking around strengthening performance beyond the regular cost areas and service lines, et cetera. Molly?
Great. And Mukesh, I just had one follow-up question for you there. When you're talking about those too many small hospitals that are in too many services, do you advise that they really examine, is it patient capacity? Should that be kind of the metric they most closely assess to determine which to, as you said, play in and which to maybe consider, reallocating or closing?
Yeah, patient capacity or overall demand is obviously a very critical indicator, but even a cost analysis, an integrated assessment of their clinical delivery capacity with specialists and what their reputation and brand is in the local marketplace. So it's not an easy decision, but at the end of the day, you are in the business of healthcare. You're also in providing healthcare to a community which needs high quality. So there has to be this balance in access, quality of care, and the cost of care. And when you look at your service lines, you have to look at it in those very lenses, which is, does this service provide access to a need in the community, or is this need duplicated or triplicated just to be in the market? Secondly, is the quality, and now we have a lot more measurement of quality, is the quality being provided to patients really competitive, or is it just something middling? And then lastly, are we making money? Is there an operating margin coming out of providing these services? Because if any of these questions has a resounding no, long-term it's not sustainable. So that's really where it all falls down, Molly.
Great, thanks, Mukesh. I think that quote you cited from Toby Cosgrove at Cleveland Clinic about the number of hospitals that did not, had little or no operating margin last year is very enlightening. And that kind of moves into our next question about academic medical centers, which are unique for many reasons. Their cost structure is unique, their patient acuity is usually more severe, and they also have research as a core part of their mission. So that kind of sets them apart in terms of some strategic insights that you might have to share. Mukesh, are there any specific insights for strategy and planning that you would put forth for AMCs in the country?
Yeah, thanks, Molly. AMCs are unique environments for healthcare delivery. So typically, an academic medical center has three arms. They have the research arm, they have the education arm, and then they have the healthcare arm. And those three work in coordination, the education being the School of Medicine, the research being creating new sciences, new cures, and then lastly, the delivery of these services. Now, the cost model, the business model, and the delivery model for each one of these is different. Traditionally, the hospital has somewhat subsidized the other two missions, the missions of education and the missions of research. In the future, this cross-subsidy will be really heavily challenged. HHS funding, based on the latest budget from the new administration, has gone down from 84.1 to 69 million. NIH funding has been reduced by 19%. And these are very significant research dollars. So very large research institutions, to continue with their research mission, will have to find new sourcing of funds beyond NIH, HHS, or the healthcare arm of the institution. That is going to be very, very critical. I think states have, who are under significant pressure in their budgeting process, have reduced their funding of state universities and private universities. So the cost of education is also going up very significantly, and including medical education. So what that translates again is that the healthcare arm of academic medical centers will be evaluated and judged more and more on a standalone basis as compared to a source of subsidy and funding for the research and for the educational arm. So that's one part of what we are seeing more and more in the AMC setting. The other thing which we are seeing is AMCs typically are 501c3s, which are not-for-profit, but their management processes are probably even lagging behind the pure health systems. So academic medical centers and how they measure performance, how they reward performance will have to change. And I'll give you an example. Typically in an academic medical center, there's an item called Dean Stats, which really represents a percent of revenue or some percent, which translates into a transference of certain monies from the health system to subsidize, as I said earlier, the research arm and the education arm. Now, that model has existed for decades. And it's built on purely a process of taxing the healthcare enterprise as compared to looking at the healthcare enterprise and their performance and the performance of the other two operating units, and then trying to figure out what sort of funding, what sort of support system should be required coming from any one of these arms. So the management model, the management processes in academic medical centers as it relates to the health system will have to be tightened, and probably some of the legacy measurements, the legacy processes, the legacy management tools have to be discarded. I think those are the two big things, Molly, from my perspective. Academic medical centers will continue to be challenged in the future.
Thanks, Mukesh. George, I want to check in with you on this question as well. Mukesh mentioned that AMCs must find new sourcing for funds, given the cuts that NIH and other agencies are facing. The management processes are lacking often in academic medical centers. Are there any other issues that you've really encountered with the centers you've worked with that you think you would advise others to kind of pay a keener and closer eye to?
I think, and Mukesh covered a lot of ground. Some of the same issues that we've already discussed. Many of the academic medical centers have made huge investments in information technology, and they need to figure out how to get value out of that. In many cases, the provider part of the organization is competing with, multi-hospital systems and community hospitals in the regions that they serve, but those community hospitals don't have the extra burden of the research or the teaching. I think one of the biggest challenges they're going to face, and Mukesh touched on this, is sort of a variation of the subsidy comments that I made about physician networks. the hospital provider side, inpatient and outpatient, is going to struggle to make enough money to cover the subsidies of the employee physician networks. The same thing is happening in academic medical centers, where the hospital inpatient outpatient provider organization is often subsidizing either the research enterprise or the teaching enterprise and helping to cover and fund the faculty practice plan. So they're going to face the same dilemma. It's harder and harder to make enough money to keep up with the subsidies and transfer the funds over, and it's going to create a conflict as the three legs of the stool battle with one another over access to funds.
Thanks, George. And this kind of, this isn't a problem unique to AMCs, but when it comes to capital expenditures and acquisitions, you've seen a lot of health systems and hospitals either develop new facilities with brick and mortar or via M&A. It's also been on the uptick. How do you think that they should go forward and proceed when they're approaching decisions about capital expenditures or acquiring or merging or affiliating with other bodies?
Well,
George, can you take this one first?
Yeah, you need to. We'll separate this into two parts. I think looking at capital expenditures needs to be done very carefully until we have a little bit more certainty as to what's coming. I think that there is a challenge in making more investments in bricks and mortar. We're seeing a migration to more and more outpatient, less and less inpatient. A lot of hospitals have beds that are out of service because there's not enough demand to keep them full. There's new competition, coming from CVS and Walgreens and Walmart, and so what you invest in needs to be done with the idea that you really fully understand that there's a demand for the service and there's going to be enough of a market to cover the cost of adding either expanding facilities or adding new facilities. That's balanced with, you need to keep up with the competition. So there is a tendency to want to go for the newest, latest technology, and if you don't have the newest, latest technology, your patients may challenge whether they want to use your facilities as opposed to somebody else's. I think that needs to be balanced with any further capital investments in IT. You've got to get and demonstrate a real ROI and value out of the IT investments that have already been made. So all of that just revolves around what do you need the capital for? Is it to upgrade, renovate your existing facilities versus adding new capacity? So all of that has to be planned very, very carefully. On the acquisition or merger front, a little bit different. The acquisitions need to be adding value in some way. If it's enhancing the footprint geographically, if it makes the organization stronger in terms of its position in the marketplace, its ability to negotiate with third-party payers to get better rates because of the position it has in the market, that adds value. Although that has to be balanced with state regulators or the FTC demanding that you don't increase costs as a result of a merger, and what they're referring to is what the payers have to pay. Going back to some comments we made earlier, I think a lot more needs to be done in looking at economies of scale, looking at the organizations you're merging with the idea that you're going to integrate into a multi-hospital system. It can't be a confederacy of individual hospitals that all have the ability to veto decisions made at the corporate office. It has to be integrated. It has to be streamlined. Some programs and services need to be consolidated in fewer locations. A lot of tough decisions, and often politically sensitive decisions that need to be made.
Thanks, George. I think that phrasing, a confederacy of independent hospitals, is really interesting and stands out to me. Mukesh, is there anything you wanted to add on here about capital expenditures and acquisitions in terms of guidance you would provide to hospitals and health systems today?
Let me talk a little bit about acquisitions, which is very fashionable right now in the provider sector. As we as consultants have engaged in the marketplace, advising our clients, there are 2 or 3 things which we have learned over the last several years. And I'm going to use some consultancies and then I'll explain. When a merger is contemplated, the incentives are aligned to project the most rosy future. So with the planning board of the state, with the outside consultants, with the financial advisors, everybody is leaning towards a future of growth and profitability, which is rarely realized. So being more realistic, more prudent, more conservative in looking at the future in a changing environment is critical. And in that context, there is a way, a terminology we use, which is, you buy growth and profitable market share. So in other words, everything is not on the come. You acquire businesses, you acquire service lines, you acquire other community hospitals to be a part of your system, not based on an expected trajectory, but really on legacy performance, where you are much more sure that 2 + 2 will be 5. 2 and 2 could possibly be 2.5 or 6, depending on what the market takes you towards. So this whole concept of profitable growth is very critical. And then execution against acquisitions post-merger is very, very important. In other words, the operationalization of merger missions, of merger goals, which would require better patient access, better clinical care, lower costs, higher profitability, higher margins, and the relentless pursuit on making that happen and providing the resources and management focus has to be critical as we go forward in a marketplace where mergers and profitable mergers are going to be more critical. We have seen far too many cases where 2 weak institutions have got together, and coming out of that is a weaker enterprise, not a stronger enterprise.
Thanks, Mukesh. I think that makes a lot of sense. So I'm going to move on to our next question, and our final question is part of the questions I have lined up for you. It might be the $1 million question, if you were to say, but where do we go from here? For our listeners listening in today, coming on the heels of last week, Mukesh, I would love to hear your thoughts first, and 2 from you, George, before we roll into Q&A with our listeners. But any parting thoughts that you would share with those listening in today?
Yeah, that's a tough question. Where do we go from here? And the answer is not as simple as clear sense of direction or magnitude of what's going to happen in 1 year or 2 years, but really where we are. And as I said in my opening statement, the tone of the administration on where we are headed. So where we are is a healthcare environment with huge pressure on hospitals and other providers to be just profitable, just to make their ordinary operating margin, which would allow them a sustainable future where they can make investments and realize against those investments to provide better care to patients. Then there is the tone of the government, which is much more restrictive in terms of financial outlays, and it will be somewhat disruptive of ACA and brings in a complexity in the marketplace of uncertainty, of people questioning whether value-based versus volume-based care is really going to be the future or not, whether population health bundle payments is going to be a cornerstone of healthcare or not. Now, if you remove a lot of the jargon, and if you remove a lot of the risks, there are some underlying elements which will not go away. The pressure on profitability, the pressure on cost management, the pressure on maximizing net revenue will be relentless and which will continue. So where we go from here is healthcare and healthcare systems continuously looking to run a more efficient operation, to remove redundancies, to create management structures and processes which would allow them to be much more agile than what they have been. The other part of this is going to be the concept of consumerism. I do think that is not going to change, irrespective of ACA, ACA, or anything else. I think the millennials are much more intelligent about making purchasing decisions regarding their health care. So you have high deductible plans, you have plans where individuals make decisions on how they are going to spend their money and their company's money in healthcare. So reorienting healthcare providers to a more friendly environment to individual patients, whether it's access, whether it's point of service, cash collection, or just branding or advertising is going to be more important in the future. The third aspect of this is going to be, the whole area of redundancy and waste and incompetency in the provision of healthcare. So in other words, why do we need 3 mammograms which don't adhere to any standard of healthcare? It could have been done in 1. And that whole thinking, mindset of defensive medicine, redundant care, complete inconsistency between and within the same practice of the testing and the provision of care will get challenged more and more. And even if, I read somewhere that even if 40% of that can be addressed, a lot of the so-called deficits can be answered to. So again, summarizing, the reason, the way to look at the future would be to continue this absolute focus on running efficient operations, respecting the patient, understanding the component of the consumer, the patient, and then lastly, removing redundancies and waste in just provision of care, in the elements of care. I think those are 3 critical things which have to be addressed in the future.
Thanks, Mukesh. And George, I want to get your thoughts on this parting question as well.
I think everybody needs to monitor what starts to happen over the next 6, 12, 18 months. We know going in that the U.S. spends more on healthcare than any other major country in the world, more per capita than any other major country in the world by far. We have the highest infant mortality rate and don't have that great of a longevity rate in comparison to other major industrialized countries. We don't provide access to healthcare to our entire population. Even with ACA, there's still tens of millions of people that have no health insurance and their only access is to hospital emergency rooms. Managing the healthcare industry in the U.S. is a complicated issue. And those of us that work in it already knew that. We've got to balance what's happening in large-scale metropolitan areas where there's multiple hospitals and many physicians and and inpatient, outpatient services and lots of competition. But there's still a large number of hospitals that are smaller, serving rural or quasi-rural communities, where they're the only community for only hospital in a community for miles and miles. So, from a public health standpoint, how do we take care of the smaller communities and allow them to have some kind of sustainable access to health care? Making the choices there, it's, access to primary care versus access to specialty care. And if they have to drive to get to specialty care, is that okay? I think we're going to see a lot more growth in telemedicine in various parts of the country, where you can get access to specialists without having to drive and without being able to employ them because there's not enough demand to cover the total cost. So there's lots of things that are coming. I agree with Mukesh. I think the younger generation may be more amenable to using telemedicine and technology as opposed to face-to-face. The other thing I think we're going to see is a renewed emphasis on personal responsibility. Now, one of the challenges that I think that the ACA had in trying to create accountable care organizations that would manage the health of a population is some of the members of the population need to do a better job of managing their own health. We already know that diabetes, obesity, and smoking are huge causes of illness. And the after effect is we treat those and then we pay for the treatment. So if we start shifting to more of a managed care kind of model where there's more risk on the potential patients as well as on the providers, that has a chance of doing something with cost. So I think there's all kinds of things on the horizon that are going to impact hospitals, health systems, and physicians, and we all need to stay awake. Thank you, Molly.
Thanks. Absolutely. Mukesh and George, thank you so much. I know that was not an easy question to answer by any means, but I think it's definitely on the forefront of our listeners' minds today, especially. So really appreciate your thoughts there. So if we're still taking questions, we are going to put on Mukesh and George's contact information, so you can feel free to email them directly with any questions we don't have the chance to get to today. Otherwise, if you have entered one so far, we do have it recorded in our system, so we will share it with them, absolutely. Wanted to make note, though, about a couple events we have coming up that are going to continue this conversation and kind of hinge on George and Mukesh's commentary and where we go from here. So next month, as part of the Hospital Review 8th Annual Meeting, Mukesh will join John Dull, who's the CFO of RWJ Barnabas Health, and Jeb Bush, the former governor of Florida, on a panel moderated by our publisher, Scott Becker, to discuss how healthcare leaders should plan for 2017 in light of the change unfolding in our capital. So if you plan on attending the meeting, this is a session not to be missed. If you're not attending the meeting, fear not. We will have an opportunity to really recap those takeaways from that panel in a May webinar, which will continue this conversation and the thoughts that were shared at the panel. So please keep an eye out for more word and information about that webinar coming out in our e-weekly newsletters. We do have one question here that we're going to take a couple minutes to unpack and get their thoughts on, and that is, how can healthcare leaders plan for long-term growth, strategic and financial, if their planning horizon has been functionally reduced to the next election cycle, when another political party might take control of Congress, resulting in potentially material changes to their business model? It's a really fascinating question. Mukesh or George, I would love to hear your thoughts on this. Essentially asking, how do you strategically plan when you're really focused on the next election and when another political party might kind of overtake things and upturn whatever progress is made under this president?
This is what. Let me. George. Go ahead, Mukesh.
Oh, okay. Thanks, George. So let me take a quick stab, and then I'll flip it over to you, George. The question is very valid, but if you look at broadly the business sector of the United States and globalization, and you see the pace of change in the auto industry, the steel industry, the technology industry, the level of change and the acceleration of change is much more pronounced than the healthcare industry is. So I understand the complexity of regulations and politics in an industry where more than half of the money flowing through the system, through the Medicare-Medicaid program, is regulated. But the concept of being agile, the concept of management processes to address changes which are coming, whether it's regulatory or competitive or global, needs to happen. So I think health systems will have to plan not 20, 30 years in advance. They'll have to plan probably 5 to 10 years. And within that framework, have some clear underpinnings, some of which we talked about in terms of operating efficiency, et cetera, and continue to drive towards that direction. The challenge sometimes is some of the infrastructure investments which the market provides, for example, in technology, for example, in buildings and other form of scientific cures. Those are the ones which I think are significantly impacted through lack of clear political or economic vision. But running the hospital themselves, I think a combination of intermediate strategic planning and operational focus on key business drivers, and again, as I said earlier, measurement of performance, incentivizing performance, and having management which drives results will probably take care of that. George?
So, I think this is a complicated issue, and I understand the question. I think some parts of the strategic planning can still be done in a manner similar to what has been done in the past, understanding the marketplace demographic characteristics and whether the population is growing or declining, whether it's aging or not, understanding who the competition is, assessing your medical staff, and do you have the right mix of physicians, what's the age profile. So a lot of the classic strategic planning things are things that you're going to want to know, and you probably need to be updating that on a more regular basis. I think the challenge with potential changes in Congress is going to be the change in the payment system. And I think as we look at it now for the next 12 to 18 months until the next election, the Republican-controlled Congress is going to be doing everything it can to try and come up with some kind of game plan to reduce taxes, which will likely involve some reduction, at least in the rate of increase in healthcare payments, if not outright reductions. Even if they continue to shoot themselves in the feet and we have the Democrats take over the Senate or the House, we're still going to fight that battle. The fact is that the cost of Medicare and Medicaid takes up too big of a slice of the economy and too big of a slice of the federal budget. So there's going to be continued push to figure out how to bring the cost down. So I think from a strategic planning standpoint, you need to understand your market, and then you need to figure that you're not going to have the luxury of as much revenue as you would like to have, and you've got to figure out how to make the economics work. And then, the competitor profile, which I skipped over, and understanding who your competitors are and who the new competitors might be as the marketplace continues to evolve. It is a very challenging environment to try and plan.
Thank you so much, Mukesh and George, for answering that, and thank you to the listener who asked that question. It was a really interesting one. This is all we have time for today. This just flew by. So I want to thank George and Mukesh for their excellent presentation. Lots of valuable insight here, and also to our listeners and audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you.